take it away from that, you should be able to share your screen. Yep.
Get myself organized here.
So you're yeah, there you go. Swap her and you're good to go.
Okay. So good afternoon, everyone. I'm Laura Lander, and I'm social work faculty in the Department of Behavioral Medicine and Psychiatry. We're going to talk about general psychosocial treatments for pregnant and postpartum women with substance use disorders. And so I'll kind of go through the different kinds of treatment. So the treatment modalities, so that's group, individual, couples kinds of modalities. The evidence-based models that are out there, which are also, models for psychosocial treatment for not pregnant patients. But then I'll address some specific for individuals with substance use and who are also pregnant or postpartum and parenting. So we'll go over our centering model that we use, as well as some other interventions for parenting patients. And then go over the topics that we generally cover with pregnant and postpartum women that are really specific to their psychosocial treatment. So just touching on why, so how psychosocial treatments help. They've been shown in general to decrease active substance use in pregnant women, increasing attendance at their prenatal care. There's a correlation between when patients are in psychosocial treatment for substance use disorders, they're more likely to come to their prenatal care appointments, reduces overdose and deaths. It absolutely improves neonatal outcomes, and I'll share a study about that in a minute, and then reduces all kinds of co-occurring medical conditions like HIV, hepatitis C, and endocarditis, which are often associated with IV substance use. Oh, for some reason that one didn't show. So I don't know why that slide's not registering, but this is actually a study looking at neonatal outcomes like birth weight and head circumference and all those outcomes that we measure, and infant mortality. And when people are in treatment for substance use disorders, all of the neonatal outcomes are also improved, like kind of those basic outcomes that get looked at, which is obviously, I always think of it as I'm treating both mom and the fetus in some ways, because as mom gets better, the developing fetus gets better inside of her, and then those outcomes are better once she gives birth. So we think about psychosocial interventions from a biopsychosocial model. So if we're in a medication-assisted treatment setting, often medication is addressing that biology. I always think of mindfulness interventions as addressing biology too, because we can help individuals regulate their nervous system, reduce heart rate, reduce anxiety, and the physiological symptoms of anxiety when we help them engage in mindfulness kinds of interventions. So I put that in the biology category too. And when we think about pregnant women, we can actually impact genetic vulnerabilities. So when we think about epigenetics, and if mom gets well, the genetic makeup that she then transmits to her baby, it can be healthier. The social, this is often addressed in kind of peer intervention settings like Celebrate Recovery, NAAA, Smart Recovery, those kinds of settings that we encourage patients to go to. And also we spend a lot of time talking about family circumstances and family relationships, improving communication strategies, setting boundaries, that gets covered and is related to the social arena. And then the psychological, so we address any mental health symptoms, helping people with coping skills to manage symptoms or tolerate symptoms, and then social skills. And family relationships kind of is in both categories, as well as self-esteem. So women who are pregnant, it's an interesting time for them. As many of you probably know, it often either during pregnancy or postpartum is a time when they reflect a lot on their own childhood. And if they have had negative experiences with being parented or traumas during their childhood, that can often get kicked back up to the surface during pregnancy and postpartum. This is so strange that there's black parts to my screen. So the general modalities, we think about individual therapy, group therapy, family therapy, couples therapy, and kind of parent-child dyadic therapy. So we're going to talk in detail about modalities and specific interventions for individual and group therapy. Just a couple of comments about family therapy. So there's an evidence-based family therapy intervention called CRAFT, which stands for Community Reinforcement and Family Training. And the nice thing about it is it actually can be done with or without the identified patient. So if the individual who has a substance use disorder is refusing to participate in treatment, this intervention can be done with the family. And what we know is if the family gets better, it absolutely impacts the patient, whether they're there or not, because the family is not enabling or dealing with their own codependency and setting boundaries better. And that will help the patient whether or not they're present in treatment. So I love the CRAFT model if you guys want to look more into that. And then couples therapy. So an example of an evidence-based couples therapy intervention is emotionally focused couples therapy. It's really grounded in attachment theory. It can be short-term, and it really helps couples improve communication and the relationship from an attachment theory perspective. Now, in order to do this, both people in the couple do need to be in recovery. So it's not recommended to engage in couples therapy of any kind while one or both individuals is in active use. And then parent-child dyadic therapy. So an example of an evidence-based intervention is parent-child interaction training, which I'll talk a little bit more about in a minute. You guys are familiar with the levels of care. So patients can enter into treatment at any of these levels, and pregnant women, sometimes it's safer to have them start with detoxification, and they can transition on to medication for opioid use disorder, and which is recommended for individuals with opioid use disorder, that they not detox off opioids. Residential treatment is the next level down, and then outpatient therapy, which can include intensive outpatient that typically meets 3 times a week, or just regular outpatient therapy once a week. And then outpatient medication for opioid use disorder. The 3 medications in pregnancy that are typically used are methadone, Suboxone, the combination product, buprenorphine and naloxone, or Subutex. Typically, we're not using Subutex anymore because of the higher rates of diversion and potential for misuse, IV misuse in particular. So in our clinic, we actually have not prescribed Subutex for pregnant women since about 2015. And there's excellent evidence out there to show that the combination product is just as safe for babies. So this is 2 slides of the list of all of the evidence-based treatments for opioid use disorder. And all of these can be delivered in either an individual therapy modality or a group therapy modality. I think most of you are really, I'm going to talk a little bit in detail about each one, but most of you are probably familiar with cognitive behavioral therapy. Community reinforcement approach really combines behavioral therapies as well as contingency management and encourages a holistic approach to recovery, often including things like vocational training. Contingency management and incentives is certainly a behavioral strategy used that we know is particularly helpful with individuals with stimulant use disorder. Dialectical behavioral therapy, which I'll talk about in a minute. Mindfulness-based practices, which I mentioned. So mindfulness-based practices and interventions are incorporated into dialectical behavioral therapy, or DBT, or they can be delivered on their own, and there's several evidence-based models. Motivational interviewing, which is really a way of talking to people about the change process. And relapse prevention in general, which is often rolled into CBT interventions. Seeking safety is another one, in particular when patients have experienced physical or sexual trauma. Seeking safety is a nice model, and they outline specific topics to cover. It's also a really flexible model in that patients do not need to discontinue use in this treatment. And so you will get dismissed from treatment if you're struggling to discontinue use, and that's really built into the model. 12-step facilitation has been studied extensively, and it's also a kind of a model that integrates multiple things, including CBT and MI and relapse prevention. And then there are 3 child dyad therapies, parent-child dyad therapies that are evidence-based: child-parent psychotherapy, parent-child interaction therapy, and the newborn behavioral observation system. And Amanda Newhouse, who is here with us, is the expert on these. So if anybody has any questions, I'm going to go over them briefly, but she knows lots about those interventions. So CBT, you guys hopefully are familiar with CBT, and it was developed by Albert Ellis and Aaron Beck. Very problem-focused, action-oriented, focusing on the present. And the goal, I usually talk about, I give this little graphic to patients that it's basically a 3-component theory about our emotions and how do we intervene with emotions if we need to. So there's the physiological component of emotion, there's the thinking part of emotions, and then there's this behavior associated with emotions. And I always tell people the good news is you can intervene in any 3 of these areas to change how you're feeling. And then just reminding people that we actually naturally change how we're feeling without doing anything. But we can do things that make our feeling worse or better, depending on our behaviors and our thinking. CBT is a collaborative model, so it's not like I'm the expert and I come in as the therapist and I'm the expert. It's really often the perspective that the patient knows the most about themselves and teaches the clinician in the process of getting better. It's active, based on open-ended questions. It's pretty structured and present focused, and often there's homework, which can be helpful because, I mean, I say we don't have to call it homework. Some people don't like that word. But if you're seeing me once a week and then you go out for an hour and then you go out into your life and however many other hours there are to your life, our therapy will be much more effective if you can actively practice some of the skills we're talking about out in your life and then report back about how that went. So community reinforcement approach is really, as I said, like an approach that uses multiple evidence-based kind of interventions in there, as we see motivational enhancement or motivational interviewing, job counseling, relapse prevention. Marital therapy can be part of it, and then social and recreational counseling can also be part of it. Contingency management. So some of you are probably doing contingency management because there's been lots of emphasis on this as we've seen a huge increase in use of methamphetamines, also among pregnant women. The rates have really gone up just as much among pregnant women as in the general population. And so the goal for contingency management is to identify specific behaviors that you want to reinforce. So those target behaviors, and then pairing them with an incentive when that target behavior occurs, or removing the incentive when it does not. And one of the most important things about contingency management is to have the incentive paired as closely with the behavior as possible. So we know that the closer they can be paired, kind of the greater the impact of the reward. So if if I give a negative urine drug screen here, you don't want to reward them like a week later, because that doesn't necessarily feel like a reward, especially with people with substance use disorders, especially with stimulant use disorder, because that immediate gratification is what helps. And what we found is with pregnant women, they don't spend a whole lot of time taking care of themselves. And so when you give them like a little gift or a reward, it actually makes a tremendous difference. It does not have to be something big. It can be something that costs 50 cents, but having it given to them by the treatment providers is incredibly meaningful. We also use memes in our contingency management, which are just fun and reinforcing messages, usually about recovery. And that in and of itself can feel really rewarding and cost some money. Just thinking about how to incorporate these into treatment settings where it doesn't cost a ton. DBT, so people probably know the 4 components of DBT are mindfulness, distress tolerance, emotion regulation, and interpersonal effectiveness. There is a specific DBT SUD model that has been developed for individuals with substance use disorder. And then mindfulness interventions, these are the 2 evidence-based treatments are mindfulness-based relapse prevention and mindfulness-oriented recovery enhancement. Mindfulness-oriented recovery enhancement really also was developed to treat co-occurring pain and opioid use disorder or pain and substance use disorder in general. So those are two treatments specific to substance use disorder, not necessarily specific to pregnant women, although pregnant women really do seem to enjoy the mindfulness-based interventions in my experience. Mindfulness-based interventions have also been shown to be very effective with individuals who have co-occurring mental health and substance use disorders, specifically like mood disorders, because it's known to be effective in treating depression, anxiety diagnoses. And then acceptance and commitment therapy also has a mindfulness component in there as well. Motivational interviewing. So again, this isn't necessarily a treatment so much as a way of talking about change and the change process, with the goal being it's collaborative, it's supportive, it's non-judgmental. It's about promoting that positive relationship between the patient and the counselor, and shown to actually increase engagement in treatment, so the person doesn't feel judged or punished if they, relapse, and reduces resistance to making change. You reinforce change talk and any active action taken in the change process. You guys are probably very familiar with relapse prevention. It's been around forever. The Gorski model is kind of the old school model of relapse prevention. It does incorporate CBT strategies. And when I think about what I do when I do relapse prevention, certainly focusing on what are the warning signs, changes in behavior, attitudes, and emotions. And sometimes people don't recognize them in themselves, and they'll say, I don't know, all of a sudden I just relapsed totally out of the blue and it came out of nowhere. When in fact, when you go back and look at the things that led up to relapse, there are all kinds of changes typically, often in those 3 areas that were warning signs that the person just was not aware of. We ask people to identify triggers, people, places, and things, and develop coping skills, including kind of rehearsing things. So we often do a role play where people are practicing refusal strategies, which when we did it in person was actually often triggering for people. So we would have to talk them down from literally having kind of a craving in that process of doing the role play. So you have to do so a little bit mindfully. Recovery planning, so having an active relapse prevention plan, especially when going into a high-risk situation like an event where people are going to be using or a setting where the patient can anticipate someone maybe using substances. And then developing kind of relapse prevention practices. So like the daily practice of doing a kind of recovery plan daily. So my recovery goals for today are 1, 2, 3, just a few very small short-term goals. And seeking safety. So again, all of these can be done in individual or group, and really focuses on empowerment and choice. It is designed for men and women, but I have found this to be really helpful for women, especially women who have experienced trauma. Because what often comes up for individuals who have experienced trauma is when they get sober, their trauma memories, or whether they be kind of cognitive memories or body memories, get kicked up because they're no longer numbing themselves with substances. So paying attention to that as people come out of active use is really important. And then 12-step facilitation. I know this is a lot. We're doing a quick overview. Has been around for a long time, and it's kind of therapy that integrates 12-step concepts. And the focus concepts are surrender, acceptance, and getting active. And attendance at 12-step meetings is really part of this intervention. And then some evidence-based mother-child work. So we mentioned child-parent psychotherapy, and that's for kids ages 0 to 6, and treatment of trauma through attachment strengthening and emotion regulation, so that both mom and child participate in that actively. Mom and child participate in all of these actively. So parent-child interaction training. This is, people may be familiar with, it's kind of the bug in the ear. So mom is actively with her child, and the interventionist or the therapist is behind a one-way mirror, and mom has kind of a audio in her ears so that the therapist can talk her through certain things, whether it be parallel play. Often parents are overly directive in their child's play, and so it really teaches parents how to both play in a healthy way with their children, as well as handle any situations that may come up, like a temper tantrum, and is kind of in the moment training. And then newborn behavioral observations is to help sensitize patients to infant communication, teach them about bonding and healthy attachment. Often this is tough for women with substance use disorders because they did not have healthy attachments with their own parents. They have lots of fear about being a good mom. And so that can prevent them from really recognizing the kinds of signs that their baby's like giving them about what their needs are. And so this can really help build that confidence that a young mother may have in how to meet her baby's needs. So what we do at Chestnut Ridge Center and our other locations is a centering model with pregnant women with substance use disorders. And this has evolved over COVID. So unfortunately, we're not in person with this anymore. So when we were in person, we used to have guest lectures. We used to give people food, and they would come for 3 hours. And we have a nurse midwife who's associated with our program who would literally be able to pull a patient out of this 3-hour treatment session and do a brief exam on them. So if they had had a C-section and their sutures were infected, she could sort of take care of that right then when they were presenting for their OB care. So it looks a little bit differently today on tele, but our nurse midwife, Kelly Lemon, is our prescriber. And she is also available to answer any pregnancy or postpartum related questions during that that medication management visit. And so it's like a one-stop shop. They can get both of their needs addressed. Now, she no longer can do physical exams at the same time as we meet because we're not in person, but maybe someday we will get back to that. And then our ACE program is also integrated into our centering program, and we have our recovery coach who's part of our groups and part of our treatment team, and also connects with patients outside of group, who's really integrated into this. And then a patient liaison as well, who can help with kind of intensive case management issues, like how do I get my ID, and housing issues, things like that. We have a relationship with pharmacy. When we were in person, we were able to get pharmacy to come to the building so that the patient didn't have to go to the pharmacy. We actually gave them their medication at the location where they received their treatment. That's not necessarily happening during tele, but again, we may get back to that. And then obviously behavioral medicine, and the Child Family Advocacy Law Clinic was a partner of ours during this time when we were in person. So you guys may be familiar with the COPE program. These are the general guidelines and how it works. And the things in pink are the ones that are specific to our pregnancy and postpartum program. Participate in peer support meetings are actually the same in each, so I'm not sure why that's pink, because I have that twice. But the nurse midwife is part of the COPE team. Peer recovery support occurs in part through our ACE program and our recovery coach. We offer nicotine replacement and contraceptive education as part of our program. And there's really a huge emphasis on retention. So we kind of retain at all costs. Now, sometimes we do need to recommend a higher level of care if a woman is pregnant and having a lot of struggles discontinuing use, but we try and really hang on to her for as long as we can until we can help her get into a higher level of care. And just a little bit more about the ACE program. I know I'm running a little short on time, so I'm gonna cruise through this. So this is how we incorporate CBT into the centering model in the group or individual setting. We help patients recognize and identify triggers that lead to use, avoid those triggers whenever possible. So I conceptualize it as internal or external triggers. Hard to avoid internal triggers because those are usually moods. And so helping people develop coping skills with internal triggers or for internal triggers. In general, the content for psychosocial groups and our general intervention is pretty kind of a combination of CBT, relapse prevention, and MI usually, and then incorporating some other theoretical models like attachment theory. But we teach about the disease model and the neurobiology of addiction. That often helps reduce guilt and shame, because patients often come to us and are like, I'm pregnant. Why can't I stop using? What's wrong with me? I'm pregnant. That should be enough. And it's like, well, actually, there's this whole brain thing happening that doesn't make it about a choice or makes it very difficult to discontinue using if you're pregnant or not. We talk about stages of change and relapse skills to help with relapse prevention, identifying triggers, as I mentioned, managing feelings, so teaching patients coping strategies, doing really some education about emotion identification, which can be really overwhelming in early recovery because people are feeling so much at once and so strongly, especially when they're pregnant. Interpersonal family relationships, we try and help folks improve those or set boundaries if the relationships are so unhealthy they can't be improved. And then establishing social supports through peer recovery. And then the content specific to pregnancy and postpartum is what to expect during pregnancy delivery. We talk a lot about that. Sometimes it's really nice to have women in a group because the women who have had babies before can help new moms with some of this. And it's really a nice collaborative and supportive environment. Certainly talk about pain management and help them with planning for pain management and talking with their providers about that versus like getting to delivery and like, oh my God, what am I going to do about my Suboxone and my pain? We used to have people discontinue their Suboxone 24 hours before delivery. We no longer do that. So patients, if they're on buprenorphine, remain on buprenorphine at the time of delivery. And if they have a C-section, they may be prescribed 2 milligrams additional to their normal dose to help them manage any pain related to the surgery. We talk about nutrition a lot, especially with pregnant women and what that looks like. We certainly talk about child protective services, not my favorite topic, but it comes up, I would say it comes up almost every group because many of our women are involved with child protective services or have fears about child protective services becoming involved with them after they deliver. We talk about the impact of medication on the fetus if they're on medication-assisted treatment. Lots of misinformation about that, certainly misinformation about breastfeeding on medication. So we try and give them correct information. So women can breastfeed on buprenorphine and methadone, just to put that out there. And not all of our providers have an awareness of that. Neonatal abstinence syndrome is another fear. You know, will my baby have withdrawal? What will that look like? How long do we have to stay in the hospital? What is the treatment? We talk about all those kinds of things. And then generally parenting comes up all the time, especially with postpartum women, and stigma. So pregnant women are the most highly stigmatized group of individuals with mental health disorders, and they interface with the healthcare system, hopefully on a regular basis. So we help them with how to manage stigma when they are feeling stigmatized, and then we advocate for them with providers and do a lot of education. This is a great resource, just to wrap things up, that is available as a PDF. So not only does it have great information about treating pregnant women with opioid use disorders, but a lot of it is pertinent to like any substance use disorder, not just opioids, but there's a whole section about medication in this guide, and it's a great resource. And then just some references. So any questions or comments? I know that was a lot of information all at once.
Please feel free to unmute or put it in the chat. If you haven't already, please use the chat to introduce yourself. We see there's a lot of double names, so please be sure to introduce yourself.
Laura, hi, it's Dr. Wonder Genus from Anthem Unicare. I just wanted to tell you thank you for this presentation. It was very well done. And as a MAT provider myself, working with pregnant women, you hit all the spots, and it was reassuring and comforting to know that I'm actually doing something right. So thank you very much. Excellent job.
Oh, thank you. Appreciate it. So, I mean, we can answer questions, or we can move on to the case, which may kind of raise some questions and prompt some discussion.
I will ask one question though. So as the DEA provider, the X-Wave provider, I'm not an obstetrician. How often, or is it recommended that these discussions be had with the obstetrician or with the X-Wave provider? Who should be having these conversations with these moms?
So which conversations?
Any and all of the above. I guess primarily I was referring to your slide that was specific for pregnant women. So talking about nutrition, CPS, NAS, pain management, all those things. Is that the responsibility of the OB provider? Is it a collaboration between the X-Wave provider, the MAP provider, and the obstetrician? And who should be making the initial contact? Is it the client who makes that initial contact, or should the MAP provider be reaching out, or vice versa, to the OB provider?
great question. So generally, I would say both and so that's why educating ourselves as either MAT providers or therapists about these issues is really important. Although if you don't know the answer, I always defer to the OB. And I generally defer to the OB with regard to anything related to prescribing medication in pregnancy. So I'm not a physician, so I don't get into what medications are safe in pregnancy, other than buprenorphine, which is within my wheelhouse. So I think what's typically recommended is when a patient comes into treatment and they are pregnant, we ask our folks to sign a release for their OB, and if they're not in OB care, we'll help to refer them to OB care if they haven't initiated that yet, and then try and have regular contact with the OB, or at least a couple times during the course of treatment, and then often direct the patient to write those questions down, because I always say, when I get in to see my doctor, all my questions go out the window. I can't remember anything, and I just want to get out of there as soon as possible. So they have to write their questions down in order to remember them, and that is totally normal when they go and see their OB. So pain management, I think, is a helpful thing for us as providers to remind the OB about, hey, this is going to be an issue. Can you make sure this comes up in the discussion, as well as, neonatal abstinence syndrome. So I think it's really both and, but, providers don't necessarily know about everything on the treatment side. And so if you don't know, certainly just making the OB aware that this is a point of discussion that's going to be really important.
Thank you. Thank you very much.
Sure. So, I have the privilege of working with Kelly, who, I learned something in every med group about pregnancy, which is great. But I certainly, not everybody has that privilege. And so having some communication with the OB is extra effort, but I think it's warranted.
And as someone, I'll just jump in real quick, as someone who is on both sides of that and participated in prenatal care with people outside, obviously, of working with them as an MAT provider, and then also having people in group, I think it's helpful for everyone starting that conversation. So do you need to be the expert in nutrition? No, but maybe if you bring kind of those pieces in when you have that time, it'll get her thinking of what she should ask her provider, so that it kind of makes makes your client be more of a participant and an advocate in her healthcare. I know from an OB side, I try to reach out to other MAT providers that people are getting care from to establish that relationship. But I think everyone can play a role in opening up the conversation for sure.
Do you find that your colleagues are open to working with MAC providers in general?
Some more than others.
That's a very general statement, but
yeah, in general,
awareness.
Yeah, in general, when I know from the OB side, when you get a letter from an MAT provider that's like, hey, I just wanted to introduce myself. This is who I am. This person's under my care, and this is what their dose is. So we already open that communication. Everyone's always really delighted. So some of my most memorable and favorite providers in the community that I've worked with are the ones that have a letter that they give to their client to bring to their next OB visit that we can scan in the chart and stuff.
Awesome.
That also always looks really good to CPS, because it shows, especially if we have a letter from you that we can put in their chart, then CPS, when they review records, is oh, look, they clearly had some communication, they sent a letter, they were confirming things early.
And how early would you recommend? I know that Laura just mentioned, when she enters, when you find out she's pregnant, that's 9 months.
Right.
That's a long time.
Yeah. So I've literally had people at their new OB visit that come in and hand me a paper, which is always super good. Obviously, the earlier you open up that conversation, it won't feel like you're packing a bunch of stuff in at the end. Something that I find that happens is sometimes we hold on to education and those kinds of like connection pieces until the very end. And then you kind of get in this frenzy of like the third trimester and she's freaking out. And then also we're throwing a bunch of crap at her. Whereas there was really some good time in the second trimester. You could have started tackling some of those things.
Okay, that's good to know. Thank you.
Any other questions before we transition? Okay, we'll thank Laura. Really appreciate your presentation, Kelly. Thanks for jumping in there as well. We will switch to the case now with Amanda. Amanda, I'll share my screen and you can walk us through. Nothing new for you as the ECHO veteran. You know this already. So.
Well,
Hold on 1 second.
Okay.
All right, go for it.
Okay. So I just want to say, Laura, you did a great job on the Diatic work too. So
That was new.
I liked it. So this is a case. So this is one that I wanted to present in parallel with this because I really just want to explore any ideas anybody has. Anything that I'm not covering, I want to make sure I'm covering all my bases because this is one of my patients who is working very, very hard in treatment. And so I just want to make sure that I am working as hard as she is. So this is a patient that I had who has a history of substance use disorder. She's been in treatment for about 5 years with us and through 3 pregnancies. She recently relapsed on March 2021 and eventually lost her children from the relapse. It was the first time CPS was involved in her case. And so we were all kind of surprised that she just automatically lost her kids in this situation. She maintained a presence in our MAT program, so she continued with group therapy, med management, and then she got re-engaged in individual therapy too about June of 2021. We then went with a diagnosis of PTSD. She had experienced some severe domestic violence, so that's what we were working on initially. And it did take her a while to get away from her partner, but she did, and she was staying on her own since September of 2021. And she worked on many treatment objectives throughout. She worked on housing, sobriety, transportation. She was doing this all alone. So one of the things was her mother had her children, so she wasn't allowed to be with her mother. They then determined she was staying with her brother and her brother had children. So they told her that she was not able to stay with her brother. So trying to follow all of these guidelines, she really became isolated. And so all of her healthy supports were no longer involved with her, which made it difficult initially. And one of the reasons she continued to go back to the unhealthy relationship. But we all know too, working with domestic violence, that is part of the cycle. And so we really worked on a lot of that initially. She's involved in domestic violence classes. She completed her parenting classes. She was on top of that. We've utilized trauma treatment and reflective practice along with motivational interviewing. And her current goals, we're working on reflecting on the past to be present for her current visitations. She's getting really frustrated. I think that it feels like the goal keeps moving that she needs to obtain. She can't identify how to build some of those healthy relationships now and the need to remain sober. And she struggled with alcohol initially, but maintained sobriety after getting back involved with treatment. But she has been sober and just really struggling. So the recent events that had happened was that she was being permitted to move with her mother. And her mother lives about an hour and a half away. So she's being permitted to move with her mother and her children. So she had to, and they told her very short notice, like, we want this to happen within 3 weeks. So she put in her 2 weeks notice at work, made her housing aware. And these are two things that she worked significantly hard for, being on her own. And then something had come up where her partner that CPS knows is very violent towards one another. Her partner had identified to possibly moving in that same area. So they thought that there was more communication, put a hold on the move, and kind of wants to reopen that back up. So now she's left without a job. It's been 2 weeks since then. She's left without a job. She's now facing eviction, right? So I just want to make sure that I'm helping her meet all of her needs. She's remaining sober through this all, which is a great strength, and she's identified that as a great strength. We've recently linked her to, as Laura was talking about, one of the benefits of our centering program is we are also connected with the School of Law. And so there's a family, and really anybody can get involved with it's a family program that they do there. So she recently got an attorney through the family program because her attorney had quit. And so in the process of all of this, so she's really struggling as some of her goals continue to shift and change. And I think that so many of our patients we work with come across this, right? Because there's so many different aspects involved. There's the legal aspect where there's court dates, UDSs, meetings, fines, there's CPS involvement where there's court dates, MDT meetings, UDSs for them as well, parenting classes, domestic violence classes, on top of some of the other struggles, right, in maintaining housing, transportation. And so I feel like there's so much on some of our patients' plates. I just want to make sure I'm not missing any aspect, because I really want to help her be successful in this situation. As she moves forward, because she does continue to remain sober, but I can see, we've been evaluating her depression each session, because I can see some of that setting in as her her visitations continue, but they've got reduced in the time frame only because of the availability of the worker or her mother. And so I can see some of these setbacks really starting to impact her. And just wanted to kind of throw that out there and get any ideas that anybody has seen in continuing to try to motivate and moving forward.
So Amanda, is her depression medically treated?
It is. So she does, yes. So she does, and she's pretty self-aware of her depression. So she does verbalize when she thinks she needs medication, and she's able to identify when she thinks that she's ready to come off and sustain herself. Her depression is not anything new. It's something that she has been dealing with throughout her life. And so she is, but that's a very good question. Yes.
So is her psychiatrist aware that this new trauma, because that's basically what it sounds like to me, could potentially trigger her into a spiraling downward trend in her mood? I mean, is there room to adjust her medication? That's one. And then the other thing is, if she's moving an hour and a half away, is she set up with a provider in her possible new area? And would that be supportive for CPS to say, hey, I've got support already in place and all these things are lined up, can we still move forward despite the fact that the ex is talking about following me there, or whatever the issue is?
Yeah, I think that's a good question. And I do her psychiatrist, she's been touching base. And luckily it's in the same facility, so we're able to maintain, but she's identified that she does not want to increase her medication. She thinks that she's in a good place. But I see her, getting more upset. And she, like I said, she's pretty self-aware. So she's like, I think I got a handle on it. So I think she's trying to stay motivated, and she's identified that she doesn't want to go on an increase in her medication. And I do, I think that that's very well phrased, Hillary. I think that saying that this is a new trauma for her, because it is, and it's triggering some of her old trauma, right? And she also has a distrust in providers now, and so she has a really difficult time. She's built a great relationship with her CPS worker, which has taken a lot of time, but I think it's also a barrier for her. In that distrust that she has sometimes, because she's almost fearful to just move closer to her mom. She's afraid that CPS is going to say, well, no, you weren't supposed to do that, and then she'll have more consequences. So she's really struggling in this like unknown and in between.
Does she have any other outside community support?
No, she had a great community support. And that's one thing we're working on now, is great suggestion, because looking at supports around her. And so one of the supports she's going to increase is her relationship with her brother. And she's been increasing that regardless if she can go and live with him or not, because she does need just that support. But she had great supports at work. And when she had to quit, they stopped they tried, but everybody gets busy and they stopped talking. And so one of the things we worked on too was her attending in-person meetings. And so she was going to work on, since our last session, going to an in-person meeting and hopefully finding a healthy connection there. But yeah, she had great relationships at work, and when she had to quit, that kind of fell through too.
Amanda, I have a question actually about her employment. From my understanding, is she kind of in a limbo period right now about moving to this new area? Is she able to contact her employer and see if she could maybe potentially get that job, like re-secure it?
Yeah, great question. She doesn't feel confident in doing that because they were really upset when she chose to leave. And so she didn't even complete her full 2 weeks. They asked her to leave before that.
Oh, I see. Okay.
Yeah.
I was going to say, in those instances, like I'm huge for employment and recovery. I wonder if maybe the treatment team could potentially reach out on her behalf, or at least try to advocate for her, or maybe that might not be an option, or if she's not comfortable with that.
She's not comfortable with that. I have talked with her and worked with her. She's not comfortable. She's moved to us collaborating with CPS now, because she was not even comfortable with that initially. But as she's built a relationship with CPS, she's become more comfortable. But she's just very nervous of any type of setback. And so she really, that's the huge barrier is with provider trust. And so and even though I've told her like everything, I would tell her everything I'm talking about and sharing, and she'd prefer not.
That's certainly understandable based on her circumstances.
Absolutely. Absolutely. And I respect that. And so anything that I've done to advocate for her, it's gone through her. So like any type of letters or anything that I could do to support her, it's gone through her. And then this way she could be well aware of any type of information I was providing. And
Got it. Well, it certainly sounds like you are advocating for her the best you can, and you're definitely in her corner for support. So
thank you. I am. I really want to see this case be successful.
Trust me, I guess.
Yeah.
Has she had good success with the child and family advocacy group contacting her?
This was just last week that she decided she's going to reach out to them. I'm so sorry. Okay. The FedEx guy is here and my dog is not going to stop barking. She was just going to, because she was supposed to be reassigned a new public defender. And so at first she didn't want to reach out to the child advocate. But she was this week. And somebody told me that she did follow. Maybe is Candy after our group said that she was following up with that. So it sounds like she's really moving forward with that.
Okay. Okay.
Why do you have a number to follow up?
I do. Well, then my brain was like, I'll talk to Amanda in treatment team.
Yeah, that'd be great.
But yeah, just because obviously everyone in probably the session realizes that I work with Amanda and Laura on stuff. So I'm also familiar with this particular case. So like kind of like my brain is just going in what do we need to do as her treatment team within her comfort level with like meeting together with CPS or like calling and putting that pressure for that referral for the advocacy center.
Yeah. Yeah.
Yeah.
Yeah, I think that's what, thank you all. This has been helpful because I think as I'm processing through with everybody and hearing everyone's feedback, I'm thinking that I just need, maybe that's where I move in a little more is just really hitting again with her about, you know, advocating, being able to advocate for her and helping her at this point, because I feel like maybe last session I got a little sense of that, but I also understand her hesitancy, so I back off. But maybe I do need to push a little bit in that area to help advocate for her.
And kind of this is like just a side note, but just in terms of like with everything else that's going on with her, if anyone else has a similar case like this, always important, like if you have that bond and relationship with them, to make sure that they're on birth control. Because these are always the times in the cases where people, like in the whirlwind of everything that happens, is when they will inevitably end up with an unplanned pregnancy. And then that's just like the final extra layer of stress that goes on.
Oh my gosh, Kelly, that's helpful too, because that's definitely not where my mind goes when I'm trying to figure out this.
Well, we've got about a minute left. Is there any other comments or questions for Amanda?
Thank you all. That really,
Yeah,
that really was
great.
very helpful. I think I'm gonna up my avocation game here.
Good deal. Well, we're glad it helped, Amanda. Thank you again for presenting it and submitting it. Just a reminder, we'll close things out here, but our next session is going to be on July 11th. So be on the lookout for the reminders for that. I see Lynn. Lynn, do we have the evaluation link, or can you send that to me at least?
I will send it to you. I
Okay.
have not gotten the updated one from the Dania Institute, so hopefully I'll get that ASAP.
Sounds good. And if there aren't any other questions or anything like that, we'll adjourn. Please be thinking about submitting a case and let us know if you need anything else. All right. Take care, everybody.
Thanks, everyone.